When the PTH levels are more, increased fracture risk can occur, and there can be weakened immunity because of vitamin D deficiency. So, what are the requirements? Between 1 and 2, one less than 1 year, 400 international units is to maintain the vitamin D for more than 20. If you have to treat patients with deficiency, you require 2,000 per day for roughly 3 months. If you want to give bolus, 50,000 once in 3 months if the compliance is poor. But thereafter, to maintain, it's only 400 international units. In children between 1 to 12 years, you require about 600,000 units per day. Deficiency, the oral therapy, 3,000 to 6,000 per day for 12 weeks, or as a bolus therapy, 1.5 lakhs for 3 months or 60,000 weekly for 6 weeks. Maintenance after correction is 1,000 international units per day. In adolescents, after 11 to 18 years, have a healthy lifestyle, half an hour walking with forearm and legs exposed to sunlight. Supplementation generally unnecessary if the diet is adequate. When you have deficiency, you go up to 60 to 10,000 per day for 8 weeks, and maintenance dose is about 1,000 international per day. So if you look at this, values ages between 1 to 18 years, the maintenance dose of what is permitted is 600 to 1,000 units per day. What about the adults? The maintenance dose is 1,500 to 2,000 international per day. The Institute of Medicine says 4,000 is the maximum, whereas the Endocrine Society's guidelines says up to 10,000. Elderly patients, the maintenance dose is about 2,000 per day. And for pregnancy lactation is also the same amount of 2,000 per day. Preferred form of vitamin D is cholecalciferol, is better than D2, that is ergocalciferol. Recheck vitamin D after 8 to 12 weeks to gauge the response in those who are deficiency. The upper limit is generally 4,000 per day for children and 10,000 per day for adults without medical supervision. Take with dietary fat, ensure the calcium intake is 1,000 to 1,000 milligram per day in the different age groups, and address the comorbid conditions like malabsorption. If there is a malabsorption, whatever calcium and vitamin D is there also not absorbed. So when you are giving this amount of calcium, about 1,000 to 1,000, 2,000 per day, unless you give calcium, your bones will not form. So as I told you, this is a summary which says roughly about 600 international units. This is what the NIN recommends also, the ICMR. The estimated recommended daily allowances of calcium is about 1,000 milligrams, whereas in children, it is between 500 to 850. And if you cross 10 years, you reach about 1,000 milligrams of calcium. Roughly, in adults, children more than 13 years up to adulthood, 1,000 milligrams is required. Pregnant and lactating women and postmenopausal women require 1,200 milligrams of calcium per day. So summary table, it gives you, see the maintenance dose is roughly about 2,000 per day. In adults, you can go up to 4,000, and elderly 2,000 per day is required. So any calcium or vitamin D supplement which you are giving, if it contains less than that, it will not do the job. So you require 500 milligrams of calcium and 2,000 of vitamin D. Up to 4,000 you can go very easily so that you can maintain strong bones. So oral vitamin D remains the most effective and cost-efficient form of supplementation in general population. Nanocapsulated vitamin D shows promise for enhanced absorption, but may be helpful in specific conditions, but is still cost prohibitive, very costly. I don't think it is worth spending on that. Liquids and spray provides excellent alternatives who have difficulty in swallowing pills or require fast absorption, but they come at a very higher cost. For a severe deficiency, intramuscular and intravenous route might be considered, but strictly under medical supervision and is typically expensive. So, what are the vitamin D recommendation for patients who are sufficient in vitamin D? If your vitamin D levels is normal, so what is the recommended daily dose? 600 per day is what I told you, up to 400. These are various guidelines, Institute of Medicine, Endocrine Society, WHO, NICE guidelines, ICMR, everyone says 600, but the upper safe limit is 4,000, is very clearly given. Key points, no high dose supplementation is required. Continue 600 to 800 either through diet or prenatal vitamins, parental vitamins, sorry, it's a spelling mistake, or mild exposure. Avoid mega doses unless there is a deficiency or specific risk factors, limited sun exposure or obesity. Regular serum monitoring is required, not required in general population as it is sufficient. So once you give vitamin D, do not make patients spend money repeatedly on vitamin D. Instead, ask them to buy the calcium. It will be fine. Then the question comes, how long to treat? Well, the half-life of vitamin D is about 4 weeks. If you say I take the treatment for about 6 months and stop it, then it's really you're letting the patient down. So typically, you give 6 to 8 weeks of high-dose therapy to raise the serum levels more than 30. So what happens next? Even after the serum level improves, the tissue and bone repletion is not complete. Continues must continue for months to years, especially in pregnancy, postpartum, with osteomalacia. Long term is required because bone stores are depleted. Bone remineralization takes 5 to 10 years in osteomalacia. Postpartum lactation increases the loss. So you take for years and years together, at least for 5 years in patients who have osteomalacia or multiple pregnancies. So the dose requirement here, longer in lactating women or those with bone pains. So you'll have to take them for a long time. In special populations, how do you recommend? Stage 3 and 5, non-dialysis patient, nutritional D2 if it's sufficient, calcitrials or analogs in advanced CKD, osteoporosis, elderly patient, pregnancy, lactation up to 2000 international per day. Obesity, malabsorption, you can go to a high 2 to 3 times higher doses. In osteomalacia and darker skin pigment, again, the repletion of 50,000 per week for 8 to 12 weeks, then a maintenance dose is to be done. People with darker skin, there is a reduced cutaneous synthesis, so it takes a longer time. You keep testing them if it's required. Clinical practice guidelines. It gives you empiric 1 to 18 years, no empiric supplementation. Here, between 1 to 18 years, to prevent nutritional loss because of the potential risk of respiratory tract infection, you give them 19 to 49 years and up to 72 years, no empiric supplementation. But in India, we have to do it. Pregnancy, you will have to supplement. So the panel assumes that all should follow 600 interlace units for age 1 to 70 years. Pregnancy and 800 in for persons age more than 70. We do not get so much of vitamin D, so we have to supplement. So D2 or D3 intake, empiric supplementation exceeds the dietary requirement if implemented without vitamin D testing. So the panel suggests against routine testing in healthy individuals who do not have established indications like hypocalcemia, etc. So now, various forms of vitamin D supplementation. Ergocalciferols, the best available, mostly effective, low cost. Ergocalciferol, low bioavailability, generally lower cost. Liquid forms, soft gels, nano complications, encapsulated vitamin D levels, everything comes with a higher cost. Effervescent tablets also. Intramuscular and intravenous injections, the costs are very heavy. There are a lot of disadvantages with the nano supplementation and soft gels, especially the taste may differ, the spray because of the alcohol and preservative used, and higher cost is what is there in the nano formulation. The best and the cheapest form is D3, the polycalciferol, may be required in higher doses if there is a malabsorption, is the most effective of where it's increasing the serum vitamin D in all the population. So the best form of supplementation is D3. Nanoparticle formulations improves the bioavailability up to 73%. Lower dose required, rapid costs, better stability, and targeted delivery. Concerns is significantly higher than the polycalciferol, not widely available in generic form, limited human data. So overkill for a general prophylaxis of mild deficiency, conventional D3 is effective and is much cheaper. So Variable standards are there in the quality nano formulations. So there is a regulatory oversight we do not know. So when do you justify the higher cost? Persistent deficiency despite standard therapy. There is some crosstalk. Can we have the crosstalk to be reduced? Could you please mute to your phones, speakers, please? All the listeners and participants, kindly mute your phones. Kindly mute your phones. Kindly mute your phones. When can higher cost be justified? Persistent deficiency despite standard therapy. When there is a GA malabsorption, need for rapid repletion.
Okay, correct.
Could the participant put off the phone and mute your speakers? There is a lot of crosstalk.
Yes, sir.
Kindly cut the
I'll
crosstalk.
mute to everyone.
Mute everyone.
Yes, sir.
If they won't, let them mute and talk.
Yes.
Why disturb others? Nanoparticle in micelle vitamin D offers significant absorption and efficacy advantages. However, the added cost in limited large-scale trials means they are best preserved for specific clinical situation, not general use. Could you please mute their phones? What is because people who want to listen also are getting distracted. Why? What is STAS therapy? STAS therapy is a high dose vitamin D therapy. A single large dose is administered in adults ranging from 3 lakh to 6 lakhs as a single dose. Mechanism is it rapidly replenishes the vitamin D deficiency in individuals with severe deficiency and restores the level to normal. High dose vitamin D rapidly rises the 24-hour oxy-D levels, which is the main form that is measured to advantages is rapid correction in patients who are unable to adhere to daily doses, and it can quickly elevate the levels. Convenience, 1 or 2 doses of high dose may all be needed for daily pills, can be taken as a single treatment, effective for patients who are elderly and pregnant women who have vitamin D deficiency levels. And indications are those with severe vitamin D deficiency, malabsorption syndrome, obesity, elderly or housebound individuals with limited mobility, chronic kidney disease and renal failure, pregnancy, people with dark skin, and individuals with darker skin and who require higher doses, postpartum or lactating women who may require a boost in vitamin D, especially if they're lactating, as breast milk typically provides low amount of vitamin D. What are the risk of toxicity? They raise the calcium levels, leading to hypercalcemia. Standard upper limit for vitamin D intake is typically around 4,000, but in stars, you reach a higher level, it can go on to toxicity. Not suitable for everyone. Recommended only in short-term use under medical supervision. Should not be used in patients with renal disease where vitamin D metabolism is impaired. Overcorrection may cause kidney or cardiovascular problems. Requires a regulation of calcium and vitamin D post-treatment. When STOS is divided, it's a quick fix. There is a patient that might become complacent, and long-term prevention of deficiency, assuming one largest dose is sufficient. That's what happens. You give 6 lakhs units and say get away. It is not the final thing. So you'll have to maintain the dose. Typical protocol, 1 lakh international unit daily for 3 to 5 days, or 3 lakh units is a single dose, or children, typically about 3 lakhs based on the age weight administered over several days. Re-evaluation, recheck at the end of 6 weeks, the vitamin D levels, if still low, repeat it. Once a level has reached about 60 nanograms, maintenance therapy of 2,000 per day or 50,000 per week can be given. Repeat if the patient is at risk of malabsorption. So STARS can be repeated once in every 6 months if it is required. But healthcare providers should be there to monitor the treatment. So which is better, 3 lakhs or 6 lakhs? 3 lakhs, there is a moderate deficiency. So 6 lakhs, if the deficiency is very severe, so risk of hypercalcemia less with 3 lakh, hypercalcemia is higher with 6 lakh unit. Monitoring is required in both the situation. So the takeaway message is 6 lakhs better for severe cases, in very severe deficiency and has been present for a long time. It is more effective in raising the levels. Faster correction, 6 lakhs unit will restore the levels normally. There is an increased risk of toxicity in hypercalcemia, particularly in renal disease and high calcium. 3 lakhs is good for moderate deficiency, low risk, and can be given for without even any problem. So, if the level is between 10 to 20, 3 lakhs is often sufficient to correct this deficiency. Now, conclusion, if this deficiency is severe, 6 lakhs might be more appropriate for correction. If the deficiency is moderate, well, 3 lakhs is much usually safer. Reasons why vitamin D is not increasing. You are giving a treatment, but it's not going up. There is a malabsorption syndrome, or vitamin D requirement is high in obese patients. Renal insufficiency, conversion to active form is not happening. Genetic factors of vitamin D receptor mutation, secondary hyperparathyroidism, liver diseases like cirrhosis and chronic hepatitis. Even if you give it will not get corrected, you will have to change the treatment. Then adequate dosing. You are not giving the correct dose to correct the sufficiency. So dose has to be adequate. Switch out intramuscular dose if it is required. Drug interactions like anticonvulsants, steroids, orlistat, and anti-TB drugs can reduce the vitamin D levels. Review the medication that may be interfering with absorption. Individuals with low sun exposure or oral vitamin may not be sufficient, especially if there is a severe deficiency. So you will have to give them injectable which is to be taken. So that's the most important thing. Approach the patient is the way. How do you approach this patient? We now saw why their values are not increasing. Now, how do you approach them? Reevaluate, ensure the diagnosis of vitamin D deficiency is correct. Check if the underlying conditions are causing the issue. Assess the absorption. If malabsorption is suspected, use parental form. Monitor the compliance adhering to therapy. Evaluate other parameters like serum, calcium, phosphate, etc., liver function test, renal function test. Otherwise, consult the endocrinologist or the gastroenterologist and nephrologist to sort out your problem. In Indian context, vitamin D is generally recommended along with calcium supplementation because we Indians have a low dietary calcium intake, roughly about 400 600, whereas the RDA is about 1200 milligrams. Vitamin D facilitates the calcium absorption. Without calcium, your vitamin D bone mineralization is not complete. So, prevention of secondary hyperparathyroidism. In calcium deficient states, the parathyroid hormone raises, there is an increased bone absorption. So calcium and vitamin D helps to suppress the bone efficiently. Indian Academy of Pediatrics Endocrine Society, they combine vitamin D with 1000 milligrams of calcium, especially important in children, adolescent, and elderly population. Avoid using high dose calcium in patients with nephrolithiasis who has got history of renal cirrhosis. Prefer a diet-based calcium in moderate cases. Supplement only when the dose is inadequate. So this is the ICMR guidelines. As I told you, in children about 500. In children who have crossed about 12 years is roughly 1000 milligrams of calcium per day. So best form of calcium is the calcium carbonate. About 40% is elemental calcium, absorbed best when given with meals as it is required. Cheapest, highly recommended, and high amount of elemental calcium. Only thing is some people will have constipation and bloating. Less absorbed if taken in empty stomach. Most common supplement in India. Good choice is to take with the food. Calcium lactate gluconate phosphate does not contain enough amount of elemental calcium. The only thing which is calcium citrate, what we use, is absorbed. It is better tolerated in those with achlorhydria, less common in India, but available also. Usually more expensive than carbonate. So most patients prefer calcium carbonate because it's cost effective and widely available. Elderly, low stomach acid, you give calcium citrate. Patients with constipation change over to calcium citrate to reduce the GI side effect. Summary, first choice is the elemental calcium, calcium carbonate, taken with food for absorption, calcium citrate in patients with gastric acidity issues like proton pump users and achlorhydria, preferred if the constipation of GI tolerance to carbonate occurs. Timing, split the dose 500 milligrams of elemental calcium twice daily for better calcium. Avoid giving more than 500 per dose because after 500, the absorption is a plateau. Algal calcium, which is commonly told, which is available. It's a plant-based source. Additional trace elements can be present. Fewer gastrointestinal side effects. Is taken with the marine algae. So limitation is costlier than the conventional calcium. Limited scale evidences to provide superiority. Available in India in correctly limited, mostly through niche or reported imported products. Trace elements contain may vary by brand, so inconsistency in the supplementation is there. So if you try to compare the calcium carbonate, citrate, algal, and lactal, the best calcium is the calcium carbonate because of the bioavailability is higher, cost is cheaper when compared to the citrate and the algal calcium. Some people are vegetarian, they say we don't take calcium carbonate, well, shift over to algal calcium, it's available. It's very cheap and easily available. So cost-effective product improves its absorption. Algal calcium is a premium plant-based option. Added minerals better for vegans. Best way is the source of whether you get vitamin D or calcium. The food source, if you see a vitamin D, fatty fish, fortified milk, vitamin D, mushroom, cod liver oil. Most of them, except the fortified milk, nothing is there for vegetarians. So you will have to supplement and milk, the cow milk, buffalo milk, paneer, cottage cheese, yogurt, ragi, sesames, almonds, etc. And the amount of calcium you get in paneer is about 200 milligrams per gram. The best is in the sesame seeds, about 1 gram of calcium per the gram. It is used in sweets and snacks, which you can take it. Vitamin D from food alone is usually insufficient. Calcium intake is often below the RDA. Fortified foods are limited, but it's increasing there. So one word about toxicity. Hypervitaminosity occurs when there is excess vitamin D in the body and there is hypercalcemia. The symptoms will be nausea, vomiting, weakness, fatigue, loss of appetite, constipation, advanced severe symptoms like kidney stones, polyuria, polydipsia, calcification of tissues. How common is it? Is very rare. Nowadays, you're finding it people who are using excess injectable forms. So overuse of supplements can occur. If you exceed 10,000 units per day for an extended period, you can have it. So how is it diagnosed? Look at the vitamin D levels. More than 150 is toxicity. Serum calcium is elevated. Creatine to assess the kidney function may be impaired. PTH is often suppressed because of high calcium. Treatment, stop vitamin D. Immediate measures, stop all the supplementation. Medical therapies, IV fluids, loop diuretics, furosemide, glucocorticoids, bisphosphonates, and dialysis in rare situations which will be required. Prevention, avoid routine vitamin D supplementation without medical supervision. Monitor the inpatients receiving high dose in medical supervision. Then you should also adhere to the recommendation of upper tolerable limits, which is there. Thank you so much. Now, if there's any questions, we will talk. Any questions? Hello? Can you hear me? Hello? Any questions? Thank you, Dr. Keshor.
ಟೈಮ್ ಪಾಸ್ ಮಾಡೋಕೆ ಬಂದಿದ್ರು ಉಲ್ಲೇಖರಿಂದ ಕೊಟ್ಟಿತ್ತು ಒಬ್ಬ ಆಳುಗಳಿಗೆ ಕೊಟ್ಟಿದ್ದೀನಿ ಒಬ್ಬಳು ತಮಿಳ್ನಾಡು ಸಂಖ್ಯೆಗೆ ಕೊಟ್ಟಿದ್ದೀನಿ ಅವಳಿಗೂ ಒಬ್ಬಳೇ ಒಬ್ಬಳು ಮಗಳು ಅವಳು ಇಂಜಿನಿಯರಿಂಗ್ ಅವಳಿಗೂ ಇಂಜಿನಿಯರಿಂಗ್ ಕೋರ್ಸ್ ಮದುವೆ ಮಾಡಿದ್ದೀವಿ ಅವಳು